Welcome back, students. Now we are going to talk about a very important aspect, and that is normal labor. So in today's lecture, you are going to learn about so many things related to normal labor, like how the process of labor begins. Then, what are the mechanisms by which pain can be relieved during normal labor? And yes, I'm also going to show you how the mechanism of labor happens with the help of gudda pelvis. Right? So let's begin the interesting topic today. So first thing is that all of us know that during pregnancy, the size of the fetus is continuously increasing. And in order to accommodate the fetus, what is happening? The uterus is stretching and the size of the uterus is also increasing. So the size of the uterus, it is increasing by hypertrophy as well as hyperplasia. Then why is it that the process of labor begins at term? There has to be something which is happening at term, which is initiating the process of labor, right? And during pregnancy, that something is absent, right? So during entire pregnancy, uterus remains in a quiescent stage, and the hormone which is responsible for making the uterus remain in a very silent, inactive mode is the hormone progesterone. Why? Because progesterone is a smooth muscle relaxant. So entire pregnancy is dominated by progesterone. So in pregnancy is a progesterone predominant condition. Right? Now, this predominance changes at the time of labor. At the time of labor, I'm going to tell you that it is not progesterone which is predominant. Now, from progesterone predominance, it changes over to estrogen predominance. Right? And how does that happen? And why does that happen? That is because at term or near term, the fetal hypothalamic pituitary axis matures. So what do you understand by this term fetal hypothalamic pituitary axis? That means now the fetal hypothalamus is going to mature. And when the hypothalamus of the fetus is going to mature, it is going to release a hormone that is called as CRH, corticotropin releasing hormone. So this is fetal CRH we are talking about. Right? Now this fetal CRH, once it is released, it is going to act on the pituitary gland of the fetus, and from the pituitary gland, from the anterior pituitary gland of the fetus, ACTH will be released. Fetal ACTH will be released. So this is normal physiology which you've already done, that from the hypothalamus CRH is released from the and this CRH acts on the pituitary, and from the pituitary ACTH is released. Now this fetal ACTH, it is going to act on the fetal adrenal glands obviously. Now this fetal adrenal gland, when it is acted upon by ACTH, it is going to produce the main substance, and the main product of the fetal adrenal glands is DHEA sulfate. What is DHEA sulfate? Dihydroepiandrosterone sulfate. Right? And this is one of the AIIMS question. They had asked what is the main product of fetal adrenal gland. So you have to remember that the main product of the adrenal fetal gland is DHEA sulfate. Right? Now, before I tell you what other thing the adrenal gland is going to produce, my question to you is that how did we start this topic? From where did the fetal hypothalamic pituitary axis reference came? The reference came because I was telling you that how is the process of labor initiated. And when I was telling you how is the process of labor initiated, I told you that the fetal hypothalamic pituitary axis matures, and from the fetal hypothalamus corticotropin releasing hormone is produced. So now if your question comes that for initiation of labor, which hormone is responsible? So which hormone is responsible? It is fetal CRH. It is the fetal CRH which is responsible for initiation of labor. And I'm going to tell you how it is responsible, right? So we saw that fetal hypothalamus released fetal CRH, then fetal CRH acted on the anterior pituitary of the fetal glands, and of the fetus, and from there it produced ACTH. ACTH acted on the fetal adrenals, and the main product of the fetal adrenal gland was DHEA sulfate. Now this DHEA sulfate, fetal DHEA sulfate, it is used by the placenta to produce estrogen. Right? If you remember the topic when we did hormones produced by placenta, there I have already told you that the placenta cannot synthesize estrogen on its own unless and until it gets precursors from the fetus, and that precursor is fetal DHEA sulfate, and this is precisely the reason why in anencephalic fetus the amounts of estrogen would be less, because in anencephalic fetus the adrenal glands are hypoplastic. This is a concept which we've done too often now, right? Now go back to the previous page and see. I was telling you here that the fetal adrenal glands, their main product is DHEA sulfate, but then they will also produce cortisol, right? So cortisol will also be produced. Now what is this cortisol going to do? This fetal cortisol is going to stimulate the placenta, and this fetal cortisol, when it stimulates the placenta, from the placenta is released placental CRH, right? So what did fetal cortisol do? It stimulated the placenta, and from the placenta, placental CRH is released. Now once this placental CRH is released, it has got multiple functions. Right? Now, I am going to tell you 4 functions here, and then 2 functions we'll be doing a little later after this. So, number 1 function of the placental CRH is that it helps in production of the placental estrogen. So, the placenta was utilizing DHEA sulfate and it was producing estrogen. Now, this placental CRH is going to come and it is going to help in the production of placental estrogen. That's number 1 function. Number 2 is this placental CRH is going to produce interleukins, interleukin 6 and interleukin 8. And it is also going to help in releasing the prostaglandin. From where are these prostaglandin released? I'll tell you shortly, right? So it helps in production of estrogen, it helps in production of interleukins, and it helps in production of prostaglandins. These are the 3 functions which I'm telling you here. Now, the 4th function which I'm telling you that this placental CRH is going to do is, this placental CRH is going to stimulate the production of fetal cortisol as well. Right? So it's going to go back and it is going to stimulate, or it is going to increase the production of fetal cortisol. Right? So this over here is a vicious cycle. Fetal cortisol was responsible for production of placental CRH. Once placental CRH is released, now it doesn't have a negative feedback, rather it has a positive feedback, and it goes and produces more of fetal cortisol. Right? Now what happens? Now over here we saw that placenta is producing estrogen with the help of DHEA sulfate, and cortisol is stimulating the placenta to produce estrogen. Right? Now the questions which they can ask you over here are, what is the most common estrogen in pregnancy? So what is the most common estrogen in pregnancy? It is estradiol, that is E2. But if they ask you what is the most specific estrogen in pregnancy, the most specific estrogen in pregnancy is E3. Third question, they can ask you, what is the main source of estrogen? Main source of estrogen is fetal DHEA sulfate. That is the substrate which the placenta uses to produce estrogen. Right? Now, again, coming back to placental CRH, I told you a few functions of placental CRH. I was telling you in that page, and in the earlier slide, I told you the function of placental CRH was it helps in, producing estrogen. Then it also produces prostaglandins, interleukins, and it stimulates the production of fetal cortisol. Not only this, what other things is placental CRH going to do? This placental CRH is going to act on the uterus, and it is going to act on the fetal membranes. Now, when it is going to act on the uterus, it is going to release PGF2 alpha from the decidua. That is why I told you that yes, it leads to production of prostaglandins, and from where the prostaglandins are produced, I'll tell you shortly. So one place from where it releases the prostaglandin, that is decidua, and the question which they ask you is, which prostaglandin is released by the decidua? So it is PGF2 alpha which is released by the decidua. Now, prostaglandin is not only released from decidua, it releases prostaglandins also from the fetal membranes. But the prostaglandin which will be released from the fetal membranes, that will be prostaglandin E, right? So from the decidua, it's PGF2 alpha, and from the fetal membranes, it is PGE. Clear to all of you? Not only this, what the CRH is going to do is, it is going to increase the number of oxytocin receptors on uterus. It will increase the estrogen receptors on uterus. It will increase the stretch receptors on uterus, and it will decrease progesterone receptors on the uterus. Please be very careful. I am not saying that it is this CRH which increases the levels of estrogen in the estrogen, it increases the levels of oxytocin. I am saying it is increasing the levels of the receptors on the uterus. So it is up-regulating estrogen receptors on the uterus, it is up-regulating stretch receptors, it is up-regulating oxytocin receptors, and it is down-regulating the progesterone receptor. That is why a few minutes back I told you that pregnancy is a progesterone predominant condition, but labor is an estrogen dominant condition, right? Now, all these changes are the ones which are responsible for initiating labor. How? When the levels of oxytocin receptors are increased, automatically the levels of oxytocin are also increased, and that leads to increase in the uterine contractions by increasing intracellular calcium. So oxytocin increases intracellular calcium, and because the intracellular calciums increase, that leads to uterine contractions, increase in the intensity of uterine contractions. So throughout pregnancy, a female was experiencing, from second trimester onwards, she was experiencing painless contractions which were Braxton Hicks contractions. Right? Now, at the time of labor, the intensity of the contractions increases, and now these contractions, they become palpable and they become painful. Braxton Hicks contractions, they were not palpable, they were not painful. Right? Now, because the oxytocin receptors have increased, the intracellular calcium increases, and that leads to an increase in the uterine contractions, and now the contractions become palpable and they become painful as well. Not only is oxytocin increasing the levels of intracellular calcium, it is prostaglandin also which increases the intracellular calcium. Right? Now, one thing which is very important at the time of labor is not just that the uterus should coordinate. It is that the uterus should contract. It is this, that the uterus should contract in a very coordinated manner. Right? Now, so that the muscle fibers of the uterus, they contract and they act in a coordinated manner, what happens is that the myometrial gap junctions increase. And this increase in the myometrial gap junctions, it is brought by the prostaglandin levels which were increasing. So prostaglandin, it is acting in two ways. Prostaglandin is increasing intracellular calcium, and it is increasing the myometrial gap junctions, which bring about a coordinated uterine contractions. Right? Now, not only this, prostaglandins are doing one more thing. Prostaglandins are acting on the cervix, and they are leading to softening of the cervix. This softening of the cervix, this is called as ripening of the cervix. And when I say that the cervix ripens, what happens is it softens because the water content increases in the cervix. Please remember that cervix, it is made up of collagen fibers, right? Now, what this prostaglandin is going to do is, it is going to break down this collagen fiber, and that is how the cervix will become soft. And this process is called as ripening of the cervix. So prostaglandins, they are increasing intracellular calcium. Prostaglandins, they are increasing your gap junctions, and prostaglandins, they are acting on the cervix as well, and they are bringing about ripening of the cervix, right? Now over here, if I ask you, in fetal membranes, which is the main prostaglandin? It is PGE2, right? So please write that also. Now, let's talk a little bit more about ripening of the cervix. So ripening of the cervix, as I told you, it means softening of the cervix. And at the time of ripening, what is happening is that the collagen content of the cervix, it is decreasing, dermatan sulfate is decreasing, and hyaluronic acid is increasing. And all these changes, they are mediated by prostaglandins. Ripening of the cervix is going to happen before true labor pains begin. So there are few events which are going to happen before the onset of true labor pains, and one of those events is ripening of the cervix. The other events which happen before true labor pain begins is lightening. All of you know what is lightening. Lightening is the head of the fetus goes down, and when head of the fetus goes down into the pelvis, the height of the uterus decreases. Now, because the height of the uterus decreases, mother will have relief from the respiratory discomfort, right? So at 36 weeks of pregnancy, what was happening is that the height of the uterus was going up till the level of Xiphisternum sternum, right? Now, because the height of the uterus was corresponding to the level of Xiphisternum sternum at 36 weeks of pregnancy, so the pregnant female was having a lot of respiratory discomfort. Now, after 36 weeks of pregnancy, the head of the fetus goes down, and because the head of the fetus goes down, the height of the uterus decreases. And because the height of the uterus decreases, mother is relieved from the respiratory discomfort and she feels light. And this is what is called as lightening, or it is also called as a welcome sign, right? Number two, the thing which happens before true labor pain begins, that is, there will be ripening of the cervix and patients may have false labor pains, right? So the Braxton Hicks contractions, they become palpable and they are irregular and they can lead to false labor pains, right? I will be telling you shortly what are the differences between false labor pains and true labor pains, right? Okay, now, so that is how the process of labor begins. Now, once the process of labor begins, for the labor to proceed, 3 P's are needed. And what are those 3 P's? Number one, first P is passage. You need an adequate passage. And by passage, I mean you need an adequate pelvis. Right? Only if the pelvis is adequate, then only delivery can happen. So you need a gynecoid pelvis, an adequate pelvis, not a contracted pelvis for delivery. And everything about pelvis we have already discussed. Number two, you need passenger. In other words, you need a fetus, and everything about fetus I have told you, the lie, the presentation, presenting part, everything. We have already done that. Right? Now, the third P which is needed for the labor to happen is the push. Right? And by push we means uterine contractions. Unless and until there are uterine contractions, till that time labor cannot begin. So let us talk about uterine contractions. So from where do the uterine contractions begin, or what is the pacemaker for the uterine contractions? So remember that the uterine contractions, they begin at the cornua of the uterus. And what is the cornua of the uterus? The angle of the uterus. So cornua of the uterus is the other name for the angle of the uterus. And most of the times it begins from the right cornua and less common is left cornua, right? Now, So they are going to begin from the cornua of the uterus and then they are going to spread throughout the uterus. And this spread is going to be at a rate of 2 centimeters per second. And within 15 seconds, the entire uterus will be depolarized. Right? So the rate of spread of uterine contractions is 2 centimeters per second and within 15 seconds, the entire organ is going to be depolarized. Right? Now, if I ask you in which part of the uterus is the contraction predominant, so please remember over here is the uterus. These are the cornua of the uterus. This is the fallopian tube. So the contractions are always maximum in the fundus of the uterus. So it is the fundus of the uterus where the contractions are predominant. And that is why the applied thing over here is, this is not just theoretical point which you have to remember. This is the applied thing that when you have to look for the intensity of the uterine contractions, you should always put your hand on the fundus of the uterus to get the correct intensity of the contractions. Right? Now, as I was telling you that throughout pregnancy, there are some painless contractions which are there, and these painless contractions are called as the Braxton Hicks contractions. So, if I ask you what is the intrauterine pressure at the time of Braxton Hicks contractions, so the intrauterine pressure at the time of Braxton Hicks contractions, that is generally less than 8 millimeters of mercury. And because it is less than 8 millimeters of mercury, that is why it is painless and it is not palpable. Braxton Hicks contractions or any contractions are going to become palpable when the intrauterine pressure will be 10 millimeters of mercury at the time of contractions. And the contractions, they become painful and they lead to dilatation of the cervix only when the intrauterine pressure is 15 millimeters of mercury. Right? So normally the intrauterine pressure during Braxton Hicks contractions, that's less than 8 millimeters. That is why they are not palpable and they are not painful. Now, gradually towards the end of the pregnancy, near term, Braxton Hicks contractions, they become palpable, but still they are not painless because their intensity reaches up till 10 millimeters of mercury. Now, once the contractions become painful and they lead to dilatation of the cervix, that means when dilatation of the cervix happens along with the contraction, that always means that their true labor pains have begun. So when I'm going to talk to you about true labor pains, I'm going to tell you this is the characteristic feature of true labor pains, that the contractions will be painful and they will lead to dilatation of the cervix. Right? So, when the contractions are painful and they lead to dilatation of the cervix, that means the intrauterine pressure is 15 millimeters of mercury. And when do you say that the contractions are moderate? We say that the contractions are moderate when the intrauterine pressure becomes 40 millimeters of mercury. Now, when the contractions are moderate, at that time, if you try and you try to indent the fundus of the uterus will not be indented when the contractions raise, the intrauterine pressure is raised to 40 millimeters of mercury. So, at this point of time, you will not be able to indent the fundus of the uterus, right? Now, as far as the characteristics of the normal uterine contractions are concerned, please remember that just now I told you that uterus, it contracts in a very coordinated manner, and that is happening because of the increase in myometrial gap junctions due to increased prostaglandin levels. Now, normal uterine contraction or normal labor, that is how you define it. That means it is going to lead to dilatation of the cervix. So, normal uterine contractions are the ones which lead to dilatation of the cervix. Not only do they lead to dilatation of the cervix, they will also lead to descent of the fetal head. So uterine contractions which are leading to dilatation of the cervix, uterine contractions which are leading to descent of the fetal head, they are called as normal uterine contractions, or that is what is your true labor pains. Right? Now, these normal uterine contractions, they will always have a polarity. Now, when I say they will have a polarity, that means when the upper part of the uterus is going to contract, the lower part of the uterus would be relaxing. Right? So, a positive and a negative polarity is maintained. It is not this that both the parts are going to contract simultaneously. Rather, I'm going to just now tell you that most of the times it is the upper part only which is contracting. Practically the lower part is the incontractile part. But still polarity is maintained. That means when the upper part is going to contract, the lower part will be just dilate. It will be passively dilating. Right? That's the next important point about the uterine contractions. Then contractions, as I told you, that they are going to be maximum at the fundus of the uterus, and from there the contraction is going to spread to the lower part of the uterus, and maximum intensity of the contraction will be at the fundus of the uterus, and as the contraction is going to come down, the intensity of the contraction will be decreasing. Right? Now, one very, very important point about these uterine contractions, what you have to remember is that it is not this that every time once the contraction begins, the uterus remains in a contracted state. No, that does not happen. Contractions are such that initially there will be contraction, then relaxation. Uterus will contract and then relax. Right? So always there is a uterine contraction which is followed by relaxation. Right? Now this relaxation is very, very important. Why? This is because when uterus contracts, the intrauterine pressure will increase. Right? And when the intrauterine pressure will increase, all of you know that pressure and volume are inversely related. So the volume of blood which is going to the fetus at the time of contractions will decrease, and that's a question. That what happens to the blood flow of the fetus at the time of contractions. So remember that when the uterus will contract, the intrauterine pressure is going to increase, and because the intrauterine pressure is going to increase, the volume of blood which is going to the fetus will decrease. So imagine if uterus remains in a contracted state, it will lead to fetal distress. So we do not want tetanic contractions. We want the uterus to relax in between, because when the uterus will relax in between, then the blood flow to the fetus is restored. Right? So relaxation is very, very important. Right? But when I say that the uterus is relaxing, that does not mean that at the time of relaxation it will have zero pressure. Right? At the time of relaxation also there is a pressure in the uterus, and that pressure is less than 20 millimeters of mercury, and that is what is called as the basal tone of the uterus. Right? So I'm telling you again what I said just now. I told you that at the time of labor, it does not happen that the entire time uterus will remain contracted. No. Contractions, they come and they go. They come and they go. They are regular, rhythmic. They come and they go. Now, so the uterus contracts and then relaxes. This relaxation is very, very important, because it is due to this relaxation that the blood flow to the fetus is restored. But when the uterus relaxes, that does not mean that the intrauterine pressure at the time of relaxation will be zero. It still has intrauterine pressure, but that intrauterine pressure is not very high. And because it is not very high, that is why the blood flow to the fetus is not decreased. right? And when I say it is not very high, by what does that mean? It is always less than 20 millimeters of mercury. And this intrauterine pressure which uterus has at the time of relaxation during labor, that is what is called as the basal tone of the uterus. Right? So have you understood, how the uterine contractions are going to happen? Uterine contractions, they are going to start from the fundus. They are going to come down. They are going to happen in a coordinated manner. They will have their own polarity. A basal tone of the uterus will always be present. Contraction has to be followed by relaxation, and these uterine contractions will lead to dilatation of the cervix, and these uterine contractions will lead to descent of the fetal head. Now, how does uterine contraction lead to dilatation of the cervix, and how does it lead to fetal descent? See, there is one very important property of the uterus which you will have to, the uterine muscle fibers which you will have to remember is, so if over here, this is the uterus, right? Now, one very important fiber property what you have to remember is that if this is the, uterine muscle fiber. Now, when the uterus relaxes, now this is a uterine muscle fiber. Now, when this muscle fiber is going to contract, its length is going to decrease, right? So, it is when the muscle contracts. Now, when this muscle is going to relax, it will not go back to its original length, right? It will become a little shorter than the original length, right? So, it becomes shorter than the original length. Clear? And this is what is called as retraction. So this is another very important property of the uterine contractions is that they lead to retraction of the uterine muscle fibers. And because the uterine muscle fibers retract, that is why the cervix dilates, right? So uterine contractions, they are responsible. See, one, they will be contracting and they will be pushing the baby down. So they will lead to descent of the fetal head. Number two, because they will be retracting, they are not going to come back to its original state. That is why they are going to lead to the dilatation of the cervix. Now imagine this. Imagine my hand over here is the uterus and this over here is the internal os, right? Now, when the uterine muscle fibers as the length, so this over here is the original length of the uterine muscle fibers. Now, what I am doing is I am decreasing the length. Now, when the length is going to decrease, when they will decrease, they are going to stretch the cervix, and because the cervix is going to stretch, right, that is why the dilatation of the cervix will happen. Right? So this was the original length of the uterine muscle fibers. This over here is the internal os, right? And now what is happening? The uterus is contracting and it is retracting also at the time of relaxation. It is not going back to its original length, and that is what leads to dilatation of the cervix. I hope I have made my point clear to all of you. Okay. So if this is clear, now let us talk about how do you define adequate uterine contractions. So many times when you have gone to your labor room, you have seen the residents talking that the uterine contractions are adequate, right? So what is understood by the term adequate uterine contractions? Adequate uterine contractions means that if there are 3 contractions which are happening in 10 minutes, right? So the frequency of the contraction should be, they should be 3 contractions in 10 minutes. This is what is called as frequency, right? Then the duration of the contraction should be that each contraction should last for 40 45 seconds. So that is the duration. So always when you are defining contractions, you have to define contractions with respect to three terms: the intensity, the duration, and the frequency. Frequency, I told you just now that if a pregnant female in labor is having 3 contractions in 10 minutes, that is adequate uterine contractions. Each contraction should last for 45 seconds and it should produce a pressure equal to 65 to 75 millimeters of mercury, or 200 to 250 Montevideo units. MV unit is Montevideo unit. I will explain you what is a Montevideo unit just now, but I want you to write this. This is what is intensity, right? So when all these 3 criteria are fulfilled, then we say that a female's contractions are adequate at the time of labor, right? There is another term which you will hear oftenly in the labor rooms, and that is tachysystole. What do you understand by tachysystole? Tachysystole means if there are more than 5 contractions in 10 minutes. Now you are going to think and tell me, tachysystole is a good thing or it's a bad thing? Tell me. If a pregnant female at the time of labor is having more than 5 contractions in 10 minutes, is it good or is it bad? See, if a female is having more than 5 contractions in 10 minutes, that means the time of relaxation has decreased, right? The contractions are happening very, very frequently. And if the time of relaxation has decreased, that means now the blood flow to the fetus will not get restored, right? And that can lead to fetal distress. So tachysystole is not a good thing to happen. This tachysystole, it can be, it can happen in spontaneous labor, but most of the time tachysystole happens in induced labor. You were giving oxytocin and the dosage of oxytocin had increased, and that can lead to tachysystole. Right? Now, tachysystole, just now I told you, it can cause fetal distress because the period of relaxation will be decreased. The contractions are happening so frequently that the period of relaxation is getting decreased. Now, when tachysystole leads to fetal distress, this is called as hyperstimulation. Although this is an outdated term, we do not use this term just now. We use tachysystole with fetal distress term. But still you have to remember this term because it could be that they can ask you in your clinical based MCQs. So, bachcho, whatever you are studying in OBS, gynae or any other subject, you have to understand it that there are clinical aspects also related to it. So whatever OBS and gynae I have taught you in Marrow edition 5, I have kept in mind all these points, that all these questions are going to be asked to you in a clinical format, right? So these are all clinically important points which you have to remember, not only to clear any exam, but because you want to become a good clinician as well, right? Okay. Now, what are the units for measuring a uterine contraction? So, if you want to measure the intensity of the uterine contraction, how do you, measure it? So, number 1 unit for measuring intensity of uterine contraction is millimeters of mercury. Just now I told you that intensity, if it is 65 to 75 millimeters of mercury. The other unit which I used was Montevideo unit, right? So there are 2 units which are used for measuring the intensity of the uterine contractions. Now, what is a Montevideo unit? Montevideo unit is the intensity of uterine contractions in millimeters of mercury multiplied by the number of contractions which are happening in 10 minutes, right? So I'm repeating this for you and then I'll give you an example so that you understand. So I am saying that Montevideo unit is the number of uterine contractions which are happening in 10 minutes. This has to be multiplied by the intensity of the uterine contractions in millimeters of mercury. So let us see this with an example. For example, so if a female is having 4 uterine contractions in 10 minutes, and each uterine contraction, its intensity is 50 millimeters of mercury, right? So each contraction's intensity is 50 millimeters. So what will be the Montevideo unit? It will be 4 multiplied by 50, which is 200 Montevideo unit, right? Now same thing I want you to apply here. I told you adequate uterine contractions are if there are 3 contractions in 10 minutes, each lasting for 45 seconds and each raising a pressure of 65 to 75 millimeters of mercury. So what is the Montevideo unit? 3 multiplied by 65 to 75, and that is why I told you that uterine contractions are adequate if the Montevideo unit is between 200 to 250 Montevideo unit. So this was something which I wanted to tell you about uterine contractions. Now before I proceed any further, see, as I told you that these uterine contractions, they are going to be painful, right? So first let us discuss that, what is the blood supply, what is the nerve supply of the uterus, what is the nerve supply of the cervix, upper vagina and perineum. Let's discuss that, and then we are going to go with pain during labor and how to get it relieved for the female, right? So if over here, please draw the uterus, right? Then we have the cervix, the vagina, and suppose over here, this over here is the perineum, right? Now, the nerve supply of the uterus, it is from T10 to L1 via the hypogastric plexus. The nerve supply of the cervix is S2 to S4 via the pelvic plexus or the sacral plexus, right? Nerve supply of upper vagina is same like the cervix, but nerve supply of lower vagina and nerve supply of the perineal area, the perineum, that is S2 to S4, but it is not via the sacral plexus or the pelvic plexus. It is via pudendal nerve, right? So this is the nerve supply of the uterus, nerve supply of the cervix, upper vagina and perineum and lower vagina. Till here it is clear to you. Now let us see that when a female is in labor, why does she have pain during labor? Now, in the first stage of labor, when there is early first stages of labor, I will be talking to you about stages of labor in the next video. But over here, I want you to know that first stage of labor is when true labor pains begin, right? And up till full dilatation of the cervix. That is 10 centimeters dilatation of the cervix. Now this first stage of labor has an early part which is called as the latent phase, and it has a later part which is called as the active phase, right? So in the first stage of labor, in the early part, pain is because of uterine contractions, right? And just now we saw that the uterus is supplied via the inferior hypogastric plexus to T10 to L1. That means in the early first stages of labor, pain is mediated by which segments? Pain is mediated by segment T10 to L1. So if I have a pregnant female who's having pain in early stages of labor and I want to relieve her pain, I will have to block which segments? T10 to L1, right? Now pain in the later first stages of labor. So in the later first stages of labor, dilatation of the cervix happens very rapidly. And because dilatation of the cervix happens very rapidly, that is why pain is due to dilatation of the cervix. And just now we saw that cervix is supplied via the nerve supply of the cervix via sacral plexus. It goes into S2 to S4, right? So in the first stage of labor, in the later part, pain is mediated by segments S2 to S4, right? Now, not only this, now pain can also be there in the second stage of labor. Second stage of labor means the cervix is fully dilated and now the fetus is being expelled, right? So when the fetus is getting expelled, the pain is happening because the lower part of the vagina is getting stretched and the perineum is getting stretched. So because the perineum is getting stretched, and we know that the perineum's nerve supply is also S2 to S4, but it is not via sacral plexus, it is via pudendal nerve. So I can very easily say that in early stages of labor, pain is mediated by segments T10 to L1. In the later stages of labor, it is mediated by S2 to S4. This demarcation, why I am telling you, you will just now understand that when I am going to tell you what is the use of paracervical block and pudendal block, right? So in S2 to S4 also what you have to remember is that although the pain mediating segments are H2 to S4, in the later first stage of labor, pain is because of dilatation of the cervix, and that is mediated by the sacral plexus or the pelvic plexus. Whereas in the second stage of labor, pain is due to stretching of the perineum and the lower vagina, and that is not mediated by the sacral plexus or the pelvic plexus. That is mediated by pudendal nerve, although the nerve roots are the same S2 to S4. Till here, have I made myself clear? Okay. Now, if I have made myself clear, so this is becoming very evident to us that in the later first stage of labor and in the second stage of labor, what is happening is that the segments S2 to S4 are getting involved, right? Now, because S2 to S4 are getting involved, that is why the true labor pains, they always lead to backache. So whenever a patient will be having true labor pains, always she will have backache because they are being mediated by S2 to S4 segments. So the referred pain of the true labor, it goes to the back because segments S2 to S4 are getting involved. Clear? Okay. So now let's talk about pain relief during labor. Now for pain relief in labor, we have three methods. Number one method is I can give some parenteral drugs which can provide pain relief, right? So the opioid analgesics, number one. Number two, I can go for regional blocks, like they can be a paracervical block or you can go for a pudendal block. Right? Or number three, you can go for neuraxial block, that is the epidural block. Right? And we are going to talk about all these three things now. Right? So first, I'm going to talk to you about the parenteral drugs which you can use to bring about pain relief. The most commonly used parenteral drugs which are used are mepridine and promethazine. The dosage of mepridine is 50 to 100 milligrams IM and promethazine is 20 milligrams IM, right? Now, when you are giving promethazine or when you are giving mepridine, then the effect is going to be seen, the maximum effect is going to be seen within 45 minutes to 60 minutes, the effect is going to come, and this effect is going to last for 4 hours, right? So the effect is going to be slow in onset and it is going to last only for 4 hours, and after 4 hours you will have to repeat the injection. Right? Now, because the effect is going to come after around 45 to 60 minutes, so then you may be tempted that let me give these injections IV. Now, if you give these injections IV, that can lead to a lot of problems during labor. For example, there is increased risk of aspiration. There is increased risk of nausea and vomiting. There is increased risk of these drugs. They can cross the placenta and they can lead to respiratory depression in the fetus. Right? And that can give a low APGAR score. Right? So it can lead to aspiration, it can lead to nausea, vomiting in the female, then it can cross the placenta and that can lead to respiratory depression in the fetus, and it can lead to low APGAR score, especially if they are used in second stage of labor. And please remember, maximum pain which a patient has is also during second stage of labor. And in second stage of labor, if I am using these drugs, these are the side effects. Right? That is why we do not use them very commonly for pain relief in labor. Right? Although they are an option, but they are not the best ones. Right? Then, number 2, you can go for a paracervical block, which, as I told you, is a regional block. So what you are doing in a paracervical block? In a paracervical block, you are blocking the pelvic plexus, which was carrying pain sensations from the cervix to the spinal cord, right? Now, where were you giving this block? You are going to give this block in the lateral fornix of the vagina. And you are going to give it, so over here, suppose this is the lateral fornix of the vagina. You have to give this block either in 2 o'clock or 4 o'clock position. Right? And you have to give it either in 10 o'clock or 8 o'clock position. Please remember, you are not going to give the block at 3 o'clock and 9 o'clock position. Why? That is because the descending cervical artery is present at 3 o'clock and 9 o'clock position. Right? So I am not going to give the block here. You can, rather than putting the block in the nerves, you can give the block in the arteries, and that can again lead to problems. Right? Now, when you are giving this block, please be very careful. I'll just show you an image over here. So you will have to use a long needle to give this block, and the long needle which you are going to use will be a 22 gauge spinal needle, which you are going to guard. The tip of the needle, you are going to guard it with your fingers, and you are going to put it in the lateral fornix of the vagina. Do not use 3 o'clock or 9 o'clock positions, because what is present there? There you will have a branch of the uterine artery, which is the descending cervical branch of the uterine artery. Right? So you have to give it just above or just below 3 o'clock position. That is why I said give it either in 2 o'clock or 4 o'clock position. And you will have to give it just below or just above the 9 o'clock position. So either you give it in 8 o'clock position or in 10 o'clock position. Right? Okay. Then, the drug which you use to give this block, that is lidocaine, that is your, the local anesthetist. Local anesthetic drug, lidocaine you are going to use. And how much lidocaine? 1% of 5 to 10 ml. Right? 1% of 5 to 10 ml lidocaine you are going to use on either sides. Right? Now, maximum lidocaine which you can use is 250 milligrams, or you can use 25 ml. That is maximum. I'm not saying 25 ml on each side. 25 ml total. Right? And this is on each side. Clear to all of you? Right. Now, the disadvantages with paracervical block are, number 1, it is very short acting. Right? So the block remains there only for 2 hours. Number 2, in 15% cases, it leads to fetal bradycardia. Why? Because what happens is that you do not keep the applied anatomy point which I told you in mind, and instead of giving the block on the nerves, you put it in the artery. And if you put it in the artery, it leads to vasospasm. And that leads to fetal bradycardia, right? The third disadvantage is that such a short block, it is going to be there. There will be a risk of fetal bradycardia and only you can use it. So tell me, in which stage of labor can you use it? It is going to block this pelvic plexus, right? This will be blocked. So if this is blocked, in which stage can you use it? You can use it only in the first stage of labor. You cannot use it in the second stage of labor. In the second stage of labor, pain is not happening due to dilatation of the cervix. It is happening because of the stretching of the perineum. And the stretch fibers from the perineum, they are being carried by the pudendal nerve. They have nothing to do with this pelvic plexus or the sacral plexus, right? So this can be used only in second stage of labor. So it is going to block only pain from the cervix and not by the pudendal nerve. So it is not used in the second stage of labor. It is used only in first stage of labor, right? So hence it can be used only in first stage of labor. It cannot be used in second stage of labor, right? Then another use where you can use it is, suppose if there is a cervical tear at the time of labor and you have to repair a cervical tear. So in order to repair a cervical tear, yes, you can use a paracervical block because it is going to anesthetize the cervix, right? So these are the uses that it can be used in the first stage of labor for pain relief. It cannot be used in the second stage of labor for pain relief, but it can be used while you are repairing cervical tears. Clear? Now, next comes pudendal nerve block. Now, pudendal nerve block, what it is doing? Pudendal nerve block is blocking the pudendal nerve, as the name is suggesting. Again, this is a regional anesthesia. The site for giving pudendal nerve block is the ischial spine. I want all of you to look at this image over here. Now, ischial spine is a very, very important landmark in entire obs and gynae. One of the reasons why it's an important landmark is because the pudendal nerve lies very close to the ischial spine, right? So the site for giving pudendal nerve block is always the ischial spine. Now, since we are looking at this image, I also want you to understand over here is, can you see a ligament which is attached to the ischial spine? That is the sacrospinous ligament. So common sense tells me that if I have to enter into the pudendal nerve, I will have to pierce which ligament? I will have to pierce the sacrospinous ligament. So write down, the ligament which is pierced is the sacrospinous ligament. Please remember, these are all questions which have either been asked or they have the potential of being asked in your exams. A lot of integrated questions are being asked. So here your anatomy knowledge is getting integrated with obstetric knowledge, right? Now, during this block, the pudendal nerve block, the drug which you are going to use will be the same like you used for paracervical block. In other words, you are going to use 1% of 5 to 10 ml of lidocaine on either sides. Maximum you can use it up till 250 milligrams or up till 25 ml. It is not 25 ml on each side. It is total 25 ml. So a thumb rule which we generally adopt is that on each side we never go beyond 10 ml, right? But yes, this block is better than a paracervical block. So the uses of pudendal nerve block are more than a paracervical block. Now, as you can see over here, definitely the uses are more. Why? Because pudendal nerve block, you are going to use it in the second stage of labor for pain relief, number one. right? So what will be the uses? Number one, in the second stage of labor for pain relief, number one. Number two, when you are applying forceps or vacuum, at that time also pain happens, and that pain is again due to stretching of the perineum, because you are trying to put the forceps are going to stretch the perineum, and that leads to pain. Right? So if I ask you during instrumental delivery, I want to relieve the pain in the patient, what should be the best method? Again, the best method should be pudendal nerve block. So number two, during instrumental delivery, you use it. Right? And number three, if there is a perineal tear or a vaginal tear, then you are going to use it for its repair. So when you are repairing a perineal tear or a vaginal tear, you are going to use pudendal nerve block. Now, in which condition are you not going to use a pudendal nerve block? You are not going to use it for relief in the first stage of labor. Right? So for first stage of labor pain, you are not going to use pudendal nerve block, and you cannot use it for cervical repair. Right? So cervical tear repair, you are not going to use pudendal nerve block. For cervical tear repair, you are going to use a paracervical nerve block. Right? Clear to all of you? Okay. Now we are going to talk about epidural block. As I told you, it is a neuraxial block. It is the best block for painless labor. So if there is a female who wants to have painless labor, this is the block which we are going to give, that is epidural block. Now for painless labor, you are going to tell me that if you are promising your patient that she is going to experience painless labor, what should be the upper level of the block? We know that the pain is happening, number one, due to uterine contractions, and uterine contractions, the nerves which are mediating them are T10 to L1, right? And pain is because of cervical dilatation, nerve segments S2 to S4. Pain is due to perineal stretching S2 to S4. So the upper level of the block, epidural block, will be T10 segments, and that's a very, very important question, right? Now, when I do epidural block, actually what am I blocking? I am doing a sensory block, and I am doing a sympathetic block. Right? So when you do epidural blockage, you are blocking the sensory nerves and you are blocking the sympathetic nervous system. Right? Now, because there will be a sensory block, that is why the pain sensations will not be felt. And because there will be a sympathetic block, it will lead to one of the disadvantages of epidural block, and that is this sympathetic block leads to vasodilatation, and this vasodilatation leads to hypotension in the mother. Right? So if I ask you what are the adverse effects of epidural block, number one adverse effects, please remember that it leads to hypotension in the mother, because there is not just sensory blockage, there is also sympathetic blockage. Is the motor system getting blocked? No. The motor fibers or the motor nerve fibers are not getting blocked. Why? Because if the motor nerve fibers, they are blocked, then the uterine contractions will stop. And that means your labor pains will stop. The uterus will stop contracting and the process of labor will not happen. That is why we are giving epidural block in such a manner that only it leads to sensory blockage and simultaneously there is sympathetic blockage also, right? But there is no motor blockage by epidural block. The drug of choice which you are going to use is bupivacaine, and its concentration is very, very important. It is 0.625% to 0.1%. Why I'm saying its concentration is important? Because if the concentration of bupivacaine, it goes higher than this, then it can lead to motor block, and that is something which we don't want, right? So if it is more than this, that was a problem. So the concentration of the drug is very, very important in epidural block. It is 0.65 to 0.625% to 0.1%. Right? Now, epidural block, it can be used in the first stage of labor and it can also be used in the second stage of labor, and that is why I told you it's the best one, right? Whereas paracervical was being used only in first stage of labor. Pudendal could be used only in second stage of labor, but epidural can be used in first as well as in second stage of labor. Now, when you are using epidural block, what is its effect on labor? So, it can lead to shortening of the first stage of labor. So, when you use epidural block, the first stage of labor automatically gets shortened, but it leads to prolongation of second stage of labor. It leads to prolongation of second stage of labor by 1 hour. Now, again, this is a very, very important point. Right? Why? Because when I'm going to tell you the normal duration of the second stage of labor in primigravida and in multigravida. Now suppose question comes and suppose I'm saying that the normal upper limit for the second stage of labor in a primigravida female is 3 hours. Now your question is saying that the female was given epidural. Right? And the second stage of labor is 3 hours. Now, are you going to call it as prolonged second stage of labor? No. Right? You are not going to call it as prolonged second stage of labor. Cut. I'll say this point again. So this point over here, which I told you just now, this has a lot of clinical application. How? Because when I'm going to tell you the normal duration of the second stage of labor, that is without epidural. Now, suppose in your question it comes that the patient was given epidural. So, what you are going to do? You are going to add 1 hour because you know that epidural, it prolongs the second stage of labor. So, second stage of labor duration, it depends upon whether you have given epidural or not. If you have given epidural, you will have to add 1 hour each. Right? Whether it is the definition of prolonged second stage of labor or whether it is the definition of second stage arrest. In both these conditions with epidural, I will have to add 1 hour each because epidural normally prolongs the second stage of labor by 1 hour. Right? Third thing, does epidural lead to increased chances of cesarean section? No. Because you are using epidural, the chances of cesarean are not increased. That's a myth, right? So the chances of cesarean section are not increased. Clear to all of you? So these are the effects of epidural. Right? So the effect of epidural on the first stage of labor, effect of epidural on the second stage of labor, and effect of epidural on the rate of cesarean section. Now, one very important thing which I want to tell you is that epidural, just now we saw that when I was giving epidural analgesia, what happened was that it led to vasodilatation, and because it led to vasodilatation, there was maternal hypotension. Right? Now, not only does this happen, epidural analgesia, because of this maternal hypotension, there is decreased placental perfusion. The placental perfusion will also decrease, and because placental perfusion is going to decrease, so hypotension is going to lead to decreased cardiac output in the mother, and because mother's cardiac output will be decreasing, there will be decreased placental perfusion. Now, when blood is coming less to the placenta, obviously blood is going less to the fetus. So this can lead to transient fetal bradycardia. Right? So epidural analgesia can lead to two side effects. Number one, it can lead to maternal hypotension. Number two, it can lead to transient fetal bradycardia. But this transient fetal bradycardia, which is happening in epidural, is happening because of vasodilatation. It is not happening because of vasospasm. Right? And that is why it is very easily treatable. So if there is transient fetal bradycardia which is happening due to epidural block, the two steps which you are going to do immediately are, number one, you are going to start IV fluids. Right? So you have to relieve the hypotension. You are going to start IV fluids, Ringer lactate or normal saline. You are going to place the mother in left lateral position. So place the mother in left lateral position and give her IV fluids. Most of the times this bradycardia is going to get relieved. If it is not getting relieved, then you may also have to give phenylephrine injection. Right? But most of the times when you will tilt the patient in left lateral position and you will give IV fluids, this bradycardia will be relieved automatically. Right? So epidural analgesia is the best analgesia which we have got. And please remember that any patient who wants to get relieved of her pain, we should give her epidural analgesia. See, we are not stopping uterine contractions. So why not patient can have a painless delivery? Rather, this is something which should be advocated to patients that they should go for painless deliveries rather than having so much of pain. Right? Now, what are the contraindications for giving epidural? See, contraindication is because epidural is leading to hypotension. So, if there is hypovolemia or if there is severe hemorrhage, then that the epidural analgesia is contraindicated. So, that's an absolute contraindication. Apart from that, increased intracranial tension, local infection, severe thrombocytopenia. Severe thrombocytopenia is when platelet count goes less than 50,000. Then there is, epidural analgesia is contraindicated. A relative contraindication for epidural analgesia is fixed cardiac output states. Fixed cardiac output states like severe mitral stenosis and severe aortic stenosis. Right? So, in these cases, yes, epidural analgesia is contraindicated, but as such, if I ask you, in heart disease patients, is epidural analgesia contraindicated? No. Your answer will be no. Rather, in heart disease patients, we give them epidural analgesia because if heart disease patients, they have pain can precipitate heart failure. Only a relative contraindication is severe MS and severe aortic stenosis. That too, it's a relative contraindication. It's not an absolute contraindication. Right? Now, just now I told you that in epidural analgesia, the level at which the block was given was T10. Now, many a times this question has been asked that for cesarean section, when you give anesthesia, what is the level for giving the anesthesia? Please remember, when you are giving anesthesia for cesarean section, you give it at T4 level and not T10 level. Why you are giving it at T4 level? Because you have to block the peritoneum also. So, in a cesarean section, because you want to block the peritoneum also, that is why the anesthesia will be given at T4 level. Right? I told you that the two most common side effects of epidural analgesia are hypotension in the mother and transient bradycardia in the fetus. Also remember, some females, when you give them epidural analgesia, they may have fever. Right? Although we don't know the reason for that fever, but some females, they have fever after giving epidural analgesia. Right? So, let's see this question over here. In this question, suppose you are given this image and they ask you the block shown in the image is used during. So first identify which block is being shown. That's very easy. Ischial spine is shown, so it has to be pudendal nerve, even if they don't write it as pudendal nerve. Right? So that means we are doing a pudendal nerve block. And if you are doing a pudendal nerve block is going to relieve the pain of stretching of the perineum, and stretching of the perineum leads to pain in the second stage of labor. So the block shown in the image is used during second stage of labor. Clear to all of you? Okay.